You're welcome to Mother and Child Antenatal Virtual Class today. I'm Dr. Amadi, medical doctor, Mother and Child Hospital. I'll be sitting in for the pediatrician, Dr. Funsho Adebayo. She's unavoidably absent today. She does send her regards. Hello, everybody. Can everybody hear me? Let's just unmute and get to meet each other. Hello,
yes,
Nasa. Hello, Faith. Hello, yes, Mrs. Mercy, Mrs. Akoyemi, Mrs. Oluwashio. Can everybody see me too?
Yes.
All right. So you're all welcome to today's class. How has the journey been? How's the journey been so far? I do hope that we're staying safe, we're eating healthy, and we're taking our vitamins, drinking a lot of water. Okay, so pregnancy is a beautiful journey. In essence, it has its ups and downs. Yes, it does. But then the good thing is that at the end of the day, you get to end it joyously when you see your little pattern of tiny feet. But all pregnancies are really not the same. So I just want to encourage everybody. Yes, there are challenges, of course there are, but just stay strong and the end is near. All right, so basically today we'll be talking about two important and common, issues that affect children at birth. Okay, so these are the things that, most mothers will encounter at one point or the other. We'll be talking about neonatal jaundice as well as infant colic in babies. Now, as mothers, we're like our children's first doctors because when they have any issues, we are really like the first to notice. Okay, so these are things that you can commonly encounter, and usually the mothers are able to pick it up quite early, even after discharge at home. So I want us today to be able to know these conditions, how to detect it early, and then what to do even at home. Okay, so we'll be going right into neonatal jaundice proper. Now, what really is neonatal jaundice? Jaundice of the newborn is very common. It actually occurs in the first 2 weeks of life, and most times it's harmless, actually. Okay? It's actually harmless. There may be some cause for alarm if the jaundice is quite severe, but it's really very common, and majority of the time, it's harmless. Jaundice simply means the yellowish discoloration of the skin of the babies or the eyes. And this can happen immediately after birth, can happen days after birth. And it's actually caused by a buildup of actually a breakdown of red blood cell substance, which we call bilirubin. Now, the first sign of jaundice is that discoloration on the child's skin. The skin will turn yellow. Okay, and the eyes too might also turn yellow, yellowish green. The eyes are usually white, though there's a white part of the eye, which is called the sclera. Now, when that turns yellow, begin to suspect that your child is having jaundice. This discoloration may also manifest in the skin. Okay, as we said, is it caused by a buildup of a substance called bilirubin. Okay, so newborns, what actually happens is that newborns have a lot of blood cells, which they don't really need. They're born with a lot of red blood cells. Now, as they are born, these red cells now begin to be broken down by the liver. So the liver has a major function of metabolizing the red blood cells. And when this happens, there is a byproduct, which is called bilirubin, that usually accumulates. Now, when this bilirubin accumulates, it stains the white part of the eye, and it can also stain the skin. The reason basically why this happens is because in the newborn, their liver is a little bit immature. There is also the excessive breakdown of cells. Now, because the liver is immature, it may not be able to completely break down the byproducts. So what happens is that the bilirubin accumulates and then stain the corresponding tissue, which is the white part of the eye and the skin. Now, the most common cause of jaundice is the harmless form, which we call physiological jaundice. It is a normal physiologic process. So it means that majority of babies will have some form of jaundice, which is harmless and which we call normal. How do you know that this kind of jaundice is harmless? Usually, with the way it starts, you may start having an idea that this may be a harmless type of jaundice. For the harmless type, also called the physiological type, which most babies will have, it will start from day 2 of life, from second to the 4th day of life, and then it will increase and get to the highest level after a week, day 7, and then later on it will fade away by the 2nd week. And this is the harmless form of jaundice. Routinely, in most practices, the child will be checked for baseline jaundice, usually within 72 hours of birth. So it means we want to be able to catch the jaundice early. By the 3rd day, most practices, we check the baseline. Even if the child doesn't appear to have any form of jaundice, it's always good to just check to be on the safe side. That way we can monitor and know that, this is the harmless jaundice. It won't cause the baby any problem. And we advise the mothers to continue breastfeeding, and continue just, doing your routine. This jaundice doesn't seem to be harmful. It's normal physiology. The level, one will compare the weight of the child, the level of the jaundice, and then, how old the child is as well. We usually plot it on a graph, okay, so that we're able to pick out children that will also tend to have the pathologic type or the bad type. So usually when we get the value, we're able to plot it on a graph and tell whether this is a very clear-cut physiological jaundice, or this is a risk, or this child falls within the high-risk zone. The child falls within the high-risk zone, it may be normal. The value may be normal for that day, but then when we check the weight, we check the age of the child, then we can tell that this will likely go up. That kind of child will need to be monitored, even if we have a normal value. Now, but how do you now know that the jaundice is the bad type, the pathologic type? How do we know that this jaundice can affect the baby adversely? Usually, if we see the jaundice very early, if you notice that the child is having jaundice on day 1, the 1st day of life, it means that this is not a good sign. Something may be going on. If the level of the jaundice is very, very high and hits the cutoff for treatment, then we know that this level is really high. It can also affect the baby. That's a bad type of jaundice. And then if the baby is unwell, if the baby is having a fever, baby is not feeding well, if the baby is irritable, then it's actually a sign that jaundice may be the pathologic type and not the normal physiologic type that a normal child will have. If you also see it even longer than 2 weeks, because as we said, the harmless type of jaundice will usually clear within a week. So then if we see it longer than 2 weeks, it's already a pointer that this jaundice is something ongoing which we need to look into. And also, if you notice there are changes in the stool, if you notice that the child's stool is looking pale and sticky, or the child's urine or the diaper is seeing like dark stains or blood stains, it actually could be a sign of a problem with the liver, which is supposed to be in charge of breaking down these red cells. As I said, physiologic jaundice is common in newborns, is a mild form of jaundice, common in children that are usually from 2 days to 3 days old. Okay, we said it peaks at day 4, and it happens within 2 to 4 days, and it peaks at day 7, and then by the 2nd week, by that time, that corresponds with the time when the liver has started, functioning much, much better. So by the 2nd week, most times the child is free of jaundice. And there are other causes of jaundice that can be harmful to the child. Okay, so we'll talk about pathologic jaundice. Common causes are problems with blood group incompatibility. In this case, the mother has a blood group which is not the same as that of the father, and likely maybe the child took that of the father. The mother's cells can actually release some, cells that can actually start fighting the baby cells, and this can result in increase in breakdown of those cells and then resultant jaundice. So if there's any incompatibility in the blood group, that can actually cause jaundice. Things like infections. Infections are very common causes of jaundice in the newborn. Prematurity, if the child is born premature, the livers are premature. These are common problems of children who are premature. And as we said, the jaundice starts very much earlier, and the level will be very, very high. Also, there are other causes of jaundice like liver disease. If the child actually has an inherent liver disease, child may be jaundice. Rhesus incompatibility. If the mother is rhesus negative and the father is positive, or the mother had other children or other pregnancies which took the father's own rhesus type, the next corresponding child could have jaundice as a result of this incompatibility. All right. There's also what we call prolonged jaundice. This happens way after 2 weeks or continues even after 2 weeks. However, the child most times is usually well. So there's a different form of jaundice that is actually prolonged. It's commonly seen in breastfed babies. So we call that breastfeeding jaundice. Majority of time it's harmless to the baby, but the child appears jaundice even months on end while they are being breastfed. This breastfeeding jaundice is actually a harmless form of jaundice, although it still needs to be monitored. Okay, still needs to be closely monitored to be sure that it doesn't reach a very high level that will be harmful to the baby. So there is a prolonged form of jaundice that is also not harmful to the baby and due to breastfeeding. Now, what to do if you notice that your baby is actually jaundiced? You need to come to the hospital. You need to come and see your doctor, see the pediatrician, see the GP, see the midwife, so they can examine the child and check the child. Majority of time, it's not really a serious problem. But as I said, we routinely take the blood level of bilirubin. We take the blood level we take a blood sample and check the level of the bilirubin to see what level the jaundice is. What we're looking out for is this level abnormal? Is it high? Does it require treatment? Because there are actually treatment options for jaundice, which we'll talk in a bit. Okay, so how do we do this test? Usually it's with a blood sample that is taken within 72 hours of birth, and then your doctor will let you know whether the level of the jaundice has gotten to the level where it needs to be treated, or one that we call the physiologic normal type most children will have, and if you need a follow-up test or monitoring. And what really is the treatment for neonatal jaundice? The first thing is, if it's just a physiologic jaundice, just increasing breastfeeding and fluid intake is usually enough. If the cause is an infection, then child will need to be treated for that infection. But the major treatment really is light therapy, phototherapy. Now, this helps use of light to break down this bilirubin that has accumulated. Once light breaks it down, it means that the bilirubin will not be easily excreted the urine or by the kidneys or by the skin. So light therapy is like our go-to treatment. We use it for moderate forms of jaundice, severe forms of jaundice. It's quite effective. The child will be under phototherapy light source for a couple of days while being monitored. And once the level of the jaundice comes down to a level that is harmless to the baby, then usually the baby is discharged. So this treatment is actually done in the hospital setting. Now, are there really any side effects? Well, there could be a few side effects, but they are very, very mild side effects. Things like, rashes, child may need a bit more fluid, may appear to be a bit more dehydrated while on light. And then, of course, it reduces the bonding time between the mother and the baby because the baby has to steadily be under the light for the treatment to work. Okay, so there are times that intermittently, the phototherapy will be stopped in between so the mother can nurse, can breastfeed, can still bond with the baby. But during the treatment, we advise a lot of fluids, a lot of breastfeeding, because the child needs a lot of fluid so she doesn't get dehydrated. Okay. Then, if light therapy doesn't work, or we have very, very, very severe forms of jaundice, there is another option, which is a step higher, which we call exchange blood transfusion. Now, this will just mean that the baby's blood will be taken and replaced. That is a way to, bring down the jaundice as quick as possible, because the problem is the bilirubin has accumulated in the blood, it's staining the skin, it's also staining the other organs, okay, and it's overwhelming the body. the major fear is a major complication of high bilirubin, which we call kernicterus. Now, kernicterus is the worst case scenario that can happen when a child is jaundice, but it's a very, very serious condition that affects the baby's brain. So something as little and as mild as jaundice can lead to something as serious as kernicterus if not treated properly. Okay, so extra blood transfusion, I said, is way to take out the baby's blood, replace it. Usually the blood is well screened. Sometimes we call the parents to donate if their blood is compatible, but it's actually a procedure that is done when really, really indicated. Okay. As I said, there's a major complication which can happen if jaundice is not treated, and that's what we call kernicterus. Now, this actually happens when the bilirubin has crossed into the brain and has damaged the brain. And what does it cause? It causes a lot of problems. Brain damage in a child that is just developing can lead to conditions like learning disorders, learning difficulties, cerebral palsy, seizure disorders, eye and hearing problems. So it can actually lead to serious problems, and it can really be life-threatening. The child actually may not survive such a serious condition, which is why we always are very vigilant when it comes to newborns with jaundice. Okay, so what really is the prognosis like? What is the outlook of jaundice? For physiologic jaundice and breastfeeding jaundice, which is like prolonged physiologic jaundice because of breastfeeding. For those forms of jaundice, it's excellent. Children are okay. It doesn't cause any long-term problems. Also, for pathologic jaundice that's picked up really early, children do very well, okay? They live normal life. They don't have any complication, so long as it is treated early before it becomes kernicterus. So kernicterus, it can be actually life-threatening, okay? And just very, very few babies actually survive such a serious condition. So which is why when your baby is born, you have to also look forward to what the jaundice screening comes out like. You also have to be vigilant at home. When you get home, you need to always check the baby's eyes. It's best to check under the sun outside, broad daylight. You'll be able to see the eyes of the child. You look at the skin, you touch it, be sure that there's no discoloration on the skin. So mothers are usually the first to tell them to be vigilant for jaundice when they get home, because it's very possible for a child to not have jaundice or to have normal, harmless form of jaundice, and then go home and then it goes very high. If you're able to pick it out early, you need to pick it out early, and you come to the hospital in time to get the appropriate treatment. So it's not something to take, lightly. It's not something to use trado medicine for or herbs and concussions from the village. It's not what you bathe the baby inside some special concussions that grandmas bring, So no, actually, jaundice is a buildup of bilirubin in the blood. There's no cream, there's no drug really that you can give the child that be able to make child pass out jaundice. If you look at what causes jaundice, you will see that the liver is not very well developed until the liver matures, which takes just a couple of days, a couple of weeks. Until that happens, it means that, and red cells are still going to continue being broken down, the baby's fetal cells. So which means that it's a process that we have to allow to take its course while looking out for jaundice, which is what we can treat. So it's not something that you manage at home. Okay, so when you have a child, when you notice your child has that yellowish discoloration of the skin or of the white part of the eyes, it's appearing yellow or appearing green, you need to hastily come to the hospital, have the baby checked, examined, have their jaundice level also checked and plotted on the graph, and see if really it hits the treatment value. If it hits the treatment line, it means that the child will need treatment. It's not a time to also hesitate with the treatment, because early treatment gives the best prognosis. So child might need phototherapy depending on the level, which is light therapy. Okay, so child might need to be under light for a couple of days while being monitored, or may need a blood transfusion depending on how bad, but that's really reserved for very, very severe forms of jaundice to save the baby's life and to prevent kernicterus. Okay, so that brings our topic for jaundice to a close. I'm thinking you can write your questions down so you don't forget. I just want to go over the next topic. It's pretty brief. It's not as long as this one. And then we'll go over all the questions together, if that's okay. I think we still have some time. All right. So secondly, we're talking about colic in babies and infants. Now, this is a very common condition. Also very distressing for parents. I think it's even more distressing for the parents than even the child, because you see a lot of parents anxious when they see it in their child. Child can't really talk, they can't express themselves, and they seem to be going through something that you wish you could be able to help them with. But unfortunately, really, it's a condition that really takes its course. Okay, so colic is actually a condition where a child will present with like repeated bouts of crying, but the child is otherwise healthy, but the child is always in some form of abdominal or tummy distress. It's very distressing to parents, as I said. Can start a few weeks after birth, but usually it's self-limiting. What I mean is that it usually goes on its own, usually between 3 to 4 months. Most children with colics will not have that again. Now, what really is colic? Now, colic is a condition where a child really cries for no apparent cause. It's really impossible to know how the child feels. Child can't talk. There are many symptoms of colic, and sometimes those symptoms also can present in some other conditions. Anyway, I said the child is usually healthy. So the child is eating well, child is feeding well, has no fever, child is not stooling, child is not vomiting, but just appears to cry unnecessarily. Okay, and it does appear to be from a tummy ache. There's been really a lot of research into what causes this tummy ache in children, and really, there's really no known cause per se. Most people describe it as irritability in children, fussing, excessive crying. They give no apparent reason. It can last up to 3 hours a day. For some people, say it's worse at night anyway. It occurs in episodes, like at least 3 times a week, and for at least 1 week in children that are up, and then it eventually goes when the child is up to 4 months of age. But it appears that the child is, however, healthy, growing well, eating well, okay, gaining weight. Child does not vomit. Their poo is normal, okay. Most of the time, the cry is like towards the evening or late afternoon. In between the cries, they're okay. Like they go back to sleep, they're fine. However, when they're having the episodes, the way they present is excessive crying. They are most times unconsolable. There's nothing you do. The child will scream. They could draw their legs up to their chest. They are red. Their face might turn red. They might act their back. Okay, they might act their back. They seem to be in a lot of discomfort. And then after the episode, they seem to be fine. Now, how are you able to tell if this is a colic or something you should be worried about? Now, if it's not due to a colic, okay, child may have all those symptoms, but then may have a rash, aside the excessive crying from tummy-ish, may have a rash, may have a fever. Child may not be pooing well or weeing well. Then you can start suspecting that this could be something else. Child is not growing well. That should cause some worry. And child is unhappy or crying, even in between the colics, child is just irritable. Then if the child is vomiting, especially if the child is vomiting, the food immediately after a feed. The child is vomiting immediately after a feed, and the vomit shoots out and can go across the room. Then you need to worry. This is not just straightforward colic. It could be a problem with the tummy. It could be what we call pyloric stenosis. So it could be another condition that affects the tummy of children aside the normal colic. And the child is breathless, having a cough, or the color changes when the baby is crying. The baby turns blue. No, that's not colic. If the child is not feeding well, it's not a good sign. It's a sign that the child is unwell. Okay, it's a sign that the child is unwell. So if you're not sure why your baby is crying excessively, or it's not really clear, if the child is well in between colics and the baby's feeding, you need to come to the hospital. And usually there are really no tests for colics, just from the history of the child being unconsolable for that particular period and being otherwise healthy, not having any other issue. that usually is a pointer that this is harmless colic. Okay. All right, there's some other things that can, present similarly with the symptoms of colic that cause abdominal pain in pregnancy in babies, such as if child has a lot of gas, maybe they're about to burp, about to pass gas. Okay, they might cry excessively sometimes. Okay, a lot of people have actually done a lot of research on colic. As I said, there's no known cause, but it's related usually with their immature digestive system. So the system is not yet mature enough to be able to digest breast milk and infant food optimally. For colic, there's really no sex. It's not really restricted to any sex. It can happen in male, in females. Okay, and as well, it can happen in children that are breastfed or infant or formula fed. Okay, so it's not specific to breastfed children or formula fed children. It can happen to any child. Okay, some other conditions that can mimic it are things like reflux. Some children do have reflux. Okay, there's childhood gastroesophageal reflux. Usually in these children, there's usually a problem with feeding. There is a problem with feeding. I'll take all your questions. Once we're done, we're almost done. There's a problem with feeding in children in reflux, but in colic, there's no problem if child feeds well, burps well. With reflux, they probably have difficulty burping, difficulty lying flat. Child may have a lot of gas in the tummy, irritable. They might prefer smaller feeds. They easily vomit their feeds. So you have to really be careful with children with colic, with reflux, because it mimics colic, but the child will have a feeding problem. Either they're vomiting their food or they can't lie flat. They might choke on their feet easily, aspirate on food easily. Okay. Also, constipation can mimic colic. The child is constipated, maybe they are poo are hard, because there's a stage in the child's development where the poo will start changing. So usually after birth, they'll just be pooing this normal, egusi, watery kind of stool, and they can poo at every feed. Okay, children can actually poo every time you breastfeed them, every time formula feed them. You can poo like 4 to 6 times a day. So long as they're feeding, they're not losing weight, they're gaining weight, they're fine. However, if the stool start getting hard, because there's a time you start weaning off breast milk, maybe introducing other food, so the stool of child may actually start changing. Child may even get constipated at some point. There's also a point in child's development where the child might even be absorbing all the breast milk. Okay, sometime around 2 to 3 months, they might absorb all the breast milk, and then their stool will start getting more formed and more hard. It might be a problem for the child at that early stage, actually. So child might be constipated. It might also cause them to cry while trying to pass that hard stool. So that is one of the things that can mimic colic as well. Then other more serious conditions like hernias, a twisted testicle or a torsion of the testes, or a twist in the bowel can mimic colic. As I said, for colic in infants, otherwise healthy child, it's fine in between the cries. Okay, feeding well, growing well. How long does colic last? It lasts like probably 3 hours. Okay, babies grow out of it from 4 to 6 months. They outgrow it, and they are very much improved by 3 to 4 months. Okay, now how common is colic? Colic is actually very common in our environment. Affects like 1 in 5 babies. Okay, so you have a baby with colic, just know that you're not alone. Many mothers have experienced it. It's common in the first 6 weeks of life. It's common in girls and boys, common in breastfed or bottle-fed. Now, what is the treatment for colic? This is the $1,000,000 question, because there's really no evidence that shows that there is any particular treatment for colic. And then the parents want a solution to their child's problems. But then, unfortunately, studies have shown that most over-the-counter remedies don't actually work. Some people will say that, oh, they've tried this, they tried that, it works, colic drop works, but then majority of the time, it doesn't do anything. It's a normal, developmental stage of the child. They outgrow it with time. So you just give the child a little bit of time, they usually outgrow it, okay? So over-the-counter remedies like colic drops, simeticone, gripe water, some of them have been around for quite some time. Yes, some of them have been around for quite some time anyway. There are also some supplements and probiotics, there's so many of them. However, as I said, research and from experience, a lot of them do not work. You won't see any significant change. So usually the child outgrows the colic phase, as I said. So what you can do at home is just to try and console the child. Okay, you can do a little bit more tummy time. So that's just turning the child and patting the back. You can bob the child a bit more often. So after feeding, you can pat the baby's back until they bob, you know. So bopping the child more often, doing a little bit more tummy time. Okay, these are things that may help. But as I said, for colic in infants is really self-limiting, and it goes on its own. So parents, you need to look after yourself too. I know it's really stressful, it's worrisome. So you see a lot of mothers, they've not gotten enough sleep, they are worried, you know. So you just need to just find a way to keep yourself sane. You know, you need to just tell yourself that this is normal. A lot of mothers have experienced it. A lot of babies are going through it. It's something that, you know, my baby will definitely outgrow in just a short period of time. Okay, so that brings us really to the end of the teaching session, and I'll be happy to take your questions now. Some people already put them in the chat box, so let me see if I can answer the ones in the chat box as fast as I can. Now, if a child is crying excessively, does that only mean the child has colic? It will mean another thing. You've answered my question. Yes, as I said, it's colic if there is no other problem in the child. It could also be a sign that there's a problem. So you need to check out that your child doesn't have a fever, a rash, check if your child has food, child has a full diaper. You need to check if child's uncomfortable or too hot or overwrapped. There's so many things that cause crying in children. Children love to cry. They really cannot talk. So that's like the only way they communicate with adults. They just cry and eat. So crying in a child a lot of times is normal. It could be a sign of colic. You just need to be more watchful, you know, as parents. Okay. Doctor, good morning. Please, is it normal for a 7-week-old to be eating every 20 to 30 minutes? As a matter of fact, he eats once he's awake. 7-week-old, 20 to 30 minutes. I would like to ask what the baby really eats. I can imagine this is a breastfed baby. Yes, actually, for breastfed babies, we say feed on demand, at least every 2 hours. For formula-fed baby, 3 hours, 3 hourly. So yes, actually, sometimes it depends on how much they sucked, you know, and if they sucked both breasts. We advise that at least you put the child on both breasts for at least 15 to 20 minutes on each of the breasts. So if the child is not full, then the child may want to eat every 30 minutes. Yes, you cannot actually withhold food from your baby at this growing stage. They actually like to eat. So that is really not a problem. I'm sure they took after somebody in the family. All right, so is there anything to prevent the occurrence of jaundice in the newborn, even while the mother is still pregnant? For the non-physiologic type, yes, there are a number of things you can do to prevent this, okay? First and foremost, you have to be healthy. You know, make sure you're attending your regular antenatal, you're building your immunity, you take your, you know, you take your immunizations you need to take while being pregnant, okay? You take your vitamins, you boost your own immune system and all, so that your child doesn't come out and then get an infection from you. Infections are common causes of jaundice in a newborn. For the other types, like when the child has a blood group incompatibility, you know, some of those things cannot be prevented because that's your blood group and that's your husband group. So just screening during antenatal helps us know that, yes, this is a child that we need to put a very close eye on, especially if the mother is a rhesus negative. Now, there's a factor called rhesus factor, which is really just put beside your blood group. Now, if you're negative and perchance your husband is positive, or you've had a previous pregnancy or baby who was positive, it means that your body and your blood cells may have been sensitized to fight any rhesus positive baby that is coming in, which will mean that in your next pregnancy, the child may have jaundice at birth. Okay, the child may have jaundice at birth because of the rhesus incompatibility factor. So what do you then do? Okay, there is what we call, there's an anti-D injection which you can take during pregnancy to actually protect the child. It's called Rogram. So they give it to the previous pregnancies in view of the next pregnancy. So if you do all this, know your blood group, your rhesus status, and then take the appropriate precautions, like taking the immunoglobulin D, the Rogram when you should, okay, then we may be able to prevent it. But as I said, there are some other types, like the blood group, the incompatibility, that until the baby is born, the baby's blood group, then we can start monitoring. Okay, so those are the few things you can do during antenatal period. All right. So how do we identify children with reflux? If the mother has reflux, can the child inherit it from the mother? Yes. Okay. This what we call childhood reflux disease. Okay. And then in such children, it will present like colic symptoms. Child might be crying, irritable, drawing the legs up and all. However, there's usually there might be a problem with feeding, with the child vomiting feet because of the reflux of the food. The child may be irritable, crying in between feet. Okay, the child may also be, unable to lie flat on the bed because of the reflux of food. So they easily aspirate on their food. They vomit a lot after feed. So if you see a child like when they burp and they burp so much of the food, then the child has reflux. Okay, the treatment really is really supportive, just like colic. They also outgrow that, okay, with frequent burping, spacing out the food, doing less quantity of food, though maybe a bit more frequent feeding. That usually helps. So usually is the feeding. You just have to manage it. They outgrow it, just like reflux, okay? So I said tummy time. Yeah, so for children who are like older than maybe 2 months, you can actually just lay them on the tummy while they're awake and try to tap their back. Probably like for like a few minutes while you're watching. We prefer children to actually lie on their back, okay, with their foot at the foot end of the cot. But then you could do tummy time. It helps, their GI system to move. It helps them burp. It also helps them, pass gas. So just practicing that, burping more often, really helps children with colic. So someone says, I am 15 weeks pregnant. I am vomiting excessively. Is it normal? Well, a bit of vomiting and nausea is expected, but that's usually seen very early on in pregnancy during the first trimester. It could just be seen as early symptoms of pregnancy. However, the 15 weeks already and you're vomiting excessively, you need to come to the hospital and get checked. It could be a sign of hyperemesis, which is an excessive type of vomiting in pregnancy. And when that happens, a lot of women pregnant that have this condition, they lose a lot of electrolyte, they lose a lot of energy, they lose a lot of strength, which is not good for the growing baby. You need to come to the hospital and get checked and have some tests done and probably to get some IV fluids, okay? So you need to come and see your gynecologist as soon as possible. All right, so what's the best position to put the sleeping child in? Face up. Face up is the best position, with a breathable cot, with breathable cover materials and cover clothes, with the baby's head at the head end of the bed and the foot at the foot end of the bed. The baby should lie on their back. There should be nothing in the cot, no extra paddings, pillows. Child really doesn't need all that, okay? So the cot is preferred to be empty to avoid sudden infant death. You don't need to pack and put a lot of things in the cot. No, you don't actually need all that. Okay, so the cot needs to be empty. The baby should lie on their back, face up. So there's still more questions. All right. Presently, my 7-week-old has something like catarrh. My 7-week-old has something like catarrh. Please, something to worry about. Yes, if you do see mucus in the baby's poo, you may need to come to the hospital and get the baby checked. It could be a sign of an infection in the tummy. Okay, it could also be nothing to worry about. So I suggest you bring the baby. We cannot know by just what you wrote. We need to look at the baby, examine the baby, probably see the poo as well to know if it's something to be worried about. All right. Also, I'm 14 weeks pregnant And eating is a problem. I'm always tired. I did not experience all this with my first baby. I'm so sorry about that. Yeah, all pregnancies are different, as I said. Pregnancies are actually different. So you may not have experienced in the last pregnancy, you may experience in this one, you may or may not experience it in the next. You really cannot tell exactly how the pregnancy will go. Okay, so if you're not eating well, it's not really a good sign. If you're always tired, it could be a sign that your blood level is low, you're not getting enough glucose in your system because you're not eating well. If you don't mind, I'd like you to come to the hospital and get yourself checked to be sure that you're not anemic, you've not lost, not a lot of blood and energy and glucose. So probably we need to come to the hospital first, check your blood level, okay, and check your electrolyte and examine you. All right, it could be a sign of malaria in pregnancy or hyperemesis in pregnancy. There are a number of things that could cause tiredness, really, in pregnancy. So you need to come around, okay? All right. So another question is, I fed him with breast milk. I fed him breast milk, but because of the way he sucks, I have to add formula. He still eats every 20 minutes. Okay. All right. So you're doing complementary feeding with formula and still eat every 20 to 30 minutes. So I'd like to ask, does he cry when he needs food? Are you the one that feeds him every 20, 30 minutes? Because it's not every time a child cries that the child needs food. Okay, it could just be that they want to be held. And maybe you're misinterpreting it as child is still hungry. Okay, so when child cries or acts like they're fussy, do just carry the child and rock him a bit and see if the child just needs maybe to be held. It may not always be food, but then children have different appetites, really. So it could just be normal for him. All right, so the next question is, doctor, I'm 24 weeks, I'm still spitting and it's very tiring. Is there a medication to stop spitting? All right. Well, it could be that you have prolonged hyperemesis. Some people actually have it longer than the first trimester. They can have it into the second and third. All right. Some people have it till the end of pregnancy. Whereas there are medications that could help your symptoms, I do not know if they will completely stop the symptoms. Okay. So there are some medications, anti-nausea medications, which we prescribe in the clinic to help with the nauseous feeling and spit ups. So you can actually come to the hospital, okay, and get a prescription for that. However, it may not stop the spitting completely, but it may help your symptoms. All right. Doctor, I'm 24. Please, does drinking cold fluids have any side effects on my baby? Please, does drinking cold fluids have any side effects on the baby or me? Because I can barely drink room temperature fluids and I'm 35 weeks gone. So people won't let me hear what. I do not think that it has any side effects on your baby, honestly. Okay, all right, but don't make it too cold anyway. So you could just make it like normal cold, but not excessively cold. But it will definitely have no effect on your baby. So next question, I'm 23 weeks pregnant. Most times I feel something dropped around my pelvic. It's painful. I don't want to ease. I feel I want to pee. Can't try, nothing comes out. Oh, okay. So it shows that you may have a urinary symptom. Okay, since it's related to the pee. So you have urgency. Could be a sign of an infection in your urine. However, I'm a bit worried about the fact that you say your pelvic drops. You need to come to the hospital to get examined. We need to test your urine and be sure there is no infection. It could be sign of an infection in your urine from down below. So do come to the hospital, okay? All right, I'm 21 weeks pregnant, currently been having excessive itching around the vulvar and anal area, also itching around my breast. All right, yes, there's some form of pruritus of pregnancy that can happen. Okay, I don't know if this just started for you, but yes, it can actually happen with pregnancy. Unfortunately, there may really be no particular complete cure until like after delivery, All right. However, it could also be a sign of something else going on with the liver. You may need to come and probably have some tests done, like a liver function test and all, to be sure that it's nothing sinister. However, it does happen with pregnancy, and unfortunately, it might be there all through pregnancy. Okay. All right. So I advise you come and see the gynae about it. Hello, doctor. I use pregnant care and the pharmacist recommend I add calcium tablets. That's okay for my baby. Do I use other regular vitamins? I mean, folic acid, calcium, and ferrous. Yes, pregnant care is good. Here we use ranferon. So really, there are many antenatal vitamins you can use. You know, from the second trimester, I advise you add calcium because baby's bones are growing. But there is Pregnant Care Max, which has calcium and some other vitamins. You do not need to buy the vitamins separately. You don't need to add other vitamins with pregnant care because pregnant care is a vitamin on its own. It has everything you need, I believe, for pregnancy. So you don't really need supplements. What you need to do is buy the particular pack that corresponds with the trimester you're in. Okay. And buy the particular pack that corresponds to the trimester. So if it's the first trimester, I think there's the regular, there's the max, okay? So the one with max has calcium and other things you may need. So you need to, upgrade that. If not, you can actually just add calcium. Which postnatal drugs can I use? Mine has finished. Okay, come to the hospital for a refill of your drugs, so you can get ranferon or pregnant care. Thank God you said cold flu does not have a on baby. Because I actually can't do without it. I think I need to reduce. You need to reduce it because too much of everything is not good. Okay, so try and reduce it. So what is Braxton Hicks? Now, Braxton Hicks are mild contractions, or abdominal pain, which are usually mild, that you have, towards the end of your third trimester. So anytime from 30 weeks, it can start coming on, it gets more stronger as you're nearing term. So they're like it's like a preparation for the main labor. So it's just your pelvic muscles and your tummy muscles are just practicing what's to come. So they're actually mild abdominal pain that women feel during their third trimester. Okay, usually harmless and they go away really. They don't really cause any harm. However, if you start having strong contractions, start seeing water or blood, going to full-on labor, you need to quickly come to the hospital. All right. So yes, I use Pregnant Care Max. Pharmacist gave me calcium. Now, I want you to check into Pregnant Care Max whether it does contain calcium because some pregnant care preparations do come with calcium. All right. So do we have any other questions today? Yes, Pregnant Care Max has 500 milligrams of calcium, vitamin D, and magnesium. So you wouldn't need any extra calcium, I believe. Now, is it only at the third trimester? Because I feel Braxton Hicks at 23 weeks. Yes, really. 23 weeks is rather early to feel Braxton Hicks. You need to come in to get checked and to have a scan, okay? All right. Okay, so if there are no other questions, let me still check if we have any other thing to talk about. All right, so do we have any other questions before we call it a day? I already answered about Braxton Hicks. I said that they are, abdominal pain that are common during the third trimester of pregnancy. They happen like in preparation for the main labor. So the womb contracts and relaxes almost immediately. It's like a false labor. Okay. All right. Some people do feel them during their late second trimester, but usually if you do feel any form of contraction in your second trimester, I'll just advise you to come to the hospital because it's commoner during the late second or third trimester, really. Okay. All right. So if you have PAL, can you do normal delivery? Well, majority of women with PAL can go ahead and do normal delivery. However, if it's really, really, really large and giving you a lot of problem, it could cause some form of challenges with birth. So may pose a challenge if they're really large, really advanced hemorrhoids or otherwise called PAL. But for majority of women with PAL, there is no problem. They go on to have normal delivery. All right. How can you know what your baby weighs before delivery? You need to do a scan in your third trimester or towards the end of your, pregnancy to know what your baby's likely weight will be. But then usually the baby, there might be some slight changes. So it's only at birth that you can know the actual weight of your baby. All right. Can you take vitamin C dissolvable tablets? Well, I think you just stick to your recommended pregnancy antenatal vitamins, okay? Because those ones already have the calculated doses that you need for, pregnancy. Things like Ranferon, Pregnant Care, and the other, antenatal vitamins are already well calculated. So don't just go over the counter and take high dose vitamin C, 1,000 grams and all that. No, shouldn't do that in pregnancy, okay? All right. So any other questions before we call it a day? I just want to commend everybody, for coming in today. Thank you so much for giving us your presence. I'm really glad to have taken this class today to encourage us on the pregnancy journey. Okay, really, it's not easy, but then there is an end and it's a glorious one. So thankfully, at the end of the day, you'll be happy that everything went, all the sacrifices you've made will pay off eventually. All right.
All right. Thank you, Dr. Amadi. We enjoyed the class. God bless you. Thank you so much.
Thank you so much for everybody. All right.
You're welcome. Bye-bye.
All right. Bye-bye. So we can end now, I guess.
Yes.
All right. Okay.